What are you telling your patients, Dustin, when you say, we're going to send this off for fancy schmancy testing?
Yes.
What do you think? Do you warn them that this is going to be great, it's going to change your life, or how do you present that to a patient?
So I think it's actually fairly easy for colon cancer to have that discussion, because regardless of what that result is, it is going to change how I treat that patient. So if we're using one of these large NGS panels to do KRAS, NRAS testing, HER2 amplification, I even like it for retesting MSI. So there is about 10% of MSI high patients that we miss by doing IHC only. And so either doing a PCR-based or an NGS-based test in addition is also important in my mind.
Even if we've got the IHC, I often repeat the genes because the concordance is not perfect, right?
Correct. I mean, and granted, this is a colon cancer panel, but MSI outside of colon cancer is a much different beast, and there are different microsatellites that are important to assay. So especially for non-colorectal cancer, performing a NGS type MSI testing is important.
And I have to tell you, selectively I've done some of the stage 3 patients. Now that sounds crazy, but selectively, especially younger patients. I just recall a recent patient who presented with a 9-centimeter tumor, no lymph nodes involved. And so MSS, all the features, there was some family history, and I still thought that there was something there that didn't make sense. A 49-year-old with a 9-centimeter tumor, there is a T4, but lymph node negative. I mean, there were about 30 lymph nodes out. So I sent it, tumor mutation burden 239, Pol E.
We're finding BRCAs, we're finding all sorts of things.
But that goes to your primary point, that essentially I had a different discussion with the patient. His system was checking this tumor. Essentially, that's why it didn't metastasize to the lymph nodes and unlikely to have metastasized beyond the primary. And I've done it a few times selectively. Do you do it on everyone? Probably not at this point for stage 3. But selectively, it may inform you, it may actually take you in a different path as well.
Mike, liquid biopsies used a lot in, say, lung cancer, even as the primary molecular diagnosis, quicker turnaround time, you control it, you're not relying on your pathologist to free up the tissue. What's your perspective on its ability to detect versus, say, tissue-based?
Well, it'd be nice to have a trial similar to the Nile trial that was done for lung in say colon, but I think given the breadth of data that's out there now, I think it clearly does detect the mutations at least as well, if not better. But the reality is that neither one is perfect, and there are mutations that are picked up on tumor tissue that you don't see in circulation and so on. Yeah. So it raises the question about whether to do both.
The reason I give you that first dibs is that not everybody, I think, may agree with that. I mean, there's the tissue-based belief that you're going to get more. They're different panels, and as a negative on a liquid, I think doesn't absolutely rule out a mutation and vice versa, right?
So if you find a BRAF V600E mutation on a liquid, it's going to be in the tissue.
Positive is a positive.
Yeah, exactly. If you don't find it, then there's a chance you may be missing it, although again, they're getting better refined with a lot of the sensitivity of the test at least. The specificity is less concerning actually than the sensitivity is. But the good news is that it's rare to find false positives that wouldn't make sense. I mean, most of those patients will have alterations that are essentially linked to a target on the tumor.
Kathy, why do I care where the tumor primary is?
Because the location has great significance in regards to, number one, potentially your treatment options that you're thinking about, as well as the overall survival of the patient.
How could this be? Why does that make any sense?
Well, we've clearly shown that right-sided tumors actually fare much worse in regards to overall survival. And then also taking into account, if you have a right-sided tumor, you should think about testing for MSI high as well as BRAF.
But that doesn't mean don't test the lefts, right?
No, that does not mean that. But,
okay, I just want to be clear.
Yes, you should
everybody gets everything.
Everyone should get
right
tested.
Right now, everybody gets everything.
Everyone should get tested. But obviously for your right-sided patient, you know that their prognosis might not be as positive. And
do you tell them that?
I don't tell them that per se. I do give them information. I don't say just because
Guess
you have a
what?
right-sided
Yeah.
tumor, you're going to decline quickly. No, I inform them that obviously right-sided tumors may be more aggressive, and that appears to be the case, and we have to be very careful about which treatments we provide to the patient and really take that into account. And we have to be prepared for considering next lines of treatment.
And sidedness and the biologics. Talk a little bit about that. I mean, we've got data there, right?
We have data. I mean, it suggests that left-sided tumors, if you're all RAS wild type, you may benefit more potentially from anti-EGFR therapy in the frontline setting. And the Europeans are large fans of that, as you know. I think a lot of time, though, for many of us, sometimes the RAS testing isn't back yet, and the patient wants to get started on therapy. And so we don't feel we feel it's appropriate to actually just go ahead and proceed with anti-VEGF therapy in that setting as well.
Yeah, I mean, to Tony's point earlier, we not only need to know RAS, we need to know BRAF, we need to know HER2, probably in that patient if you're going to use EGFR frontline. So that's now maybe 20%, maybe less than that, who are then candidates.
Yeah, I mean, the pie keeps on shrinking, right? Exclude the right, exclude the RAS, the RAS mutated, the BRAF V600E mutated, the HER2 amplified. There probably are others as well. But if you have all that in hand, it's great. But most of the times that patient's presenting to us and we don't. You know, if you look actually at the...
Let me Mike, so if in a metastatic patient, right-sided, okay, with METs, but let's make them asymptomatic METs. Is this, do I have to give FOLFIRINOX Bev to this patient?
Well, FOLFOXIRI Bev.
Whichever one.
So the TRIBE trial was interesting. As I was sitting through it, I was almost sinking in my seat because I don't like to give triple drug therapies to the average, particularly older colon cancer patient. But I now wonder about that, based on the data that was presented. And we're going to talk more about TRIBE
we are,
later.
but I'm just saying, we got this data that, again, back to sidedness, that right-sideds are worse. There's some data that suggests that we counter that in some ways with a more aggressive therapy.
Right.
Am I required to be more aggressive in that setting?
I don't know that you necessarily have to be more aggressive. I mean, these are individual discussions with patients, and
so I can still give a right-sided colon cancer patient FOLFOX Bev if I want to.
I wouldn't have concern. In fact, I mean, obviously there's other information. If they're MSI high, I'd see Tony's disagreeing with this. Okay.
I will disagree with
too.
this. I think if you we're going to talk about TRIBE too. If you look at the numbers, I know they don't look fancy, the 27-month, but that's actually much better than the right-sided EGFR inhibitor. Absolutely. But the point is that now we have to be selective, of course. I mean, if it's your 80-year-old patient, I mean, for God's sake, we're not going to give them FOLFOXIRI. But if you're comfortable giving FOLFIRINOX to a pancreas cancer patient, I don't see why you shouldn't be comfortable considering FOLFOXIRI for a colorectal cancer.
I agree with you.
But so the concern, I hear this all the time, is I've used all my drugs. We have been preaching for the last 5-6 years that it's sequential therapy. It's making sure that all the patients are exposed to all the drugs. So now we're kind of changing our tune then and saying that some sort of induction intensive therapy pays off long term.